Welcome in Glukowas, nice city of Poland. This is in this hospital behind me, the Hospital of Ministry of Internal Affairs and Administration, where a specific rehabilitation program was implemented last year for COVID-19 survivors. This program was designed by Professor Jan Cegiełniak, who is the head of Physical Therapy Department. And with his team, he takes care about the patients with post-COVID-19. Professor, thank you very much for allowing us to organize this event in your department. Could you tell us a little bit more about the activity of your center?
Our nationally recognized medical center provides continuous stationary rehabilitation program for over 100 patients, post-COVID-19 patients, during 3 weeks therapy cycle for each. Recently we went over 2,000 patients taken care since the beginning of the program more than 14 months ago, and we have been fully occupied all this time.
And what are the main objectives of rehabilitation that you have set up for COVID-19 patients, and which equipments are dedicated to this type of rehabilitation?
Most of the patients suffer pulmonary complication during and after COVID-19, but there is more with it. Very often patients have comorbid symptoms coming from cardiovascular system, central and peripheral nervous system, memory problems. Our center and rehabilitation program is concentrated on pulmonary and cardiovascular system. That's why most of therapy methods and equipment are aiming for. Our personal's work is often supported by technology, which makes their work easier. But in some cases recently developed, technology brings more possibilities than therapist's hand can do. One of them is Simeox.
Effectively, pulmonary rehabilitation for post-COVID-19 patients is quite similar to rehabilitation for patients with chronic respiratory disease. And in this context, what are the indications of Simeox technology for your patients?
The center is using now Simeox therapy as an adjunct ACT for treating more efficiently patients with persistent dyspnea, fatigue and impaired lung function associated with sputum problems. Simeox is indicated in chronic respiratory disease for clearing airways.
Thank you, Professor. I wish you a great time with us, and we have the opportunity to talk and discuss about the challenge of pulmonary rehabilitation in post-COVID-19 patients.
Thank you. Welcome.
According to ERS ATS Task Force, post-COVID-19 patients should benefit from a multidisciplinary rehabilitation program for cardiorespiratory, mental health, and also neuromuscular disorders. Patients with pre-existing lung disease should benefit from pulmonary rehabilitation, but not only, also patients with long-term respiratory sequelae induced by COVID-19 disease. Last year's conference made a focus on COVID-19 cares and told us that 75% of patients hospitalized for severe or critical COVID-19 disease are eligible for pulmonary rehabilitation. 25% of these patients are re-hospitalized in the following months. Pulmonary rehabilitation, these patients have exertional dyspnea, air trapping, gas exchange impairment, and persistent pulmonary damage. ERS confirmed that pulmonary rehabilitation improves significantly lung function, dyspnea, and fatigue in post-COVID-19 patients. We are glad to start this program with Professor ZIORA from Medical University of Silesia.
I'm Dariusz, ZIORA, I'm head of Department of Pneumonology and Tuberculosis, Silesian University of Medicine. It's a great honor and great privilege to me to invite you to a very short lecture about pulmonary abnormalities after COVID-19 pneumonia. So, as you know, during clinical course of this disease, the several phases are well known. After incubation and after symptomatic phase, we can observe early pulmonary phase and late pulmonary phase with immune dysregulation and cytokine storm, which ultimately can lead to the death in several percent of patients, and with T-cell dysfunction. So pathological changes responsible for lung injury compromise not only diffuse alveolar damage and abnormal lung veins, but also organizing pneumonia, which is seen in about 40 to 50% of patients. Of course, we can observe bronchopneumonia focal with bacterial superinfection, where we can observe thrombosis and pulmonary embolies. These changes, pathological changes, are manifested by CT as ground glass opacity, ground glass with consolidation, and very often mixed changes are seen. Also subpleural line and pulmonary fibrosis and bronchus distortion. During the time of illness, we can observe slow resolution of ground glass opacities. However, consolidation and linear opacities may progress in some cases. After discharge, the residual changes are more probably in patients with a high CT score and with involvement above 3 lung segments. So, I'm wanted to know what does it mean day of discharge from hospital. So, in my opinion, the day of discharge from hospital doesn't mean the end of COVID-19 pathological process. Not always we can recognize the patient completely cured and free from symptom. So, let us see what happened 3 weeks after hospital discharge. About 50% of patients had still CT abnormalities, mainly ground glass opacities. What happened next? 2 months after discharge, 50% of patients had still dyspnea, 30% had cough, fatigue, depression, and about 40% of patients had still X-ray changes. In 9% of cases, we can see even progression of these radiological pathological changes. 3 months after COVID-19, 28 patients were in poor health status. Only 7% declared good health status relatively. And dyspnea, cough, fever, diarrhea, night sweats, pain were the most often described complaints of these patients. Also, pathological CT findings are observed in about 63% of patients, which dominating ground glass opacities, reticulation and consolidation. What about lung function test abnormalities? After 3 months, we can observe diminished diffusion capacity and restriction in 17% of patients. Obturation is present only in 8% of our patients. But cardiopulmonary exercise capacity is also reduced. As you can see, 1/3 of participants experienced a low maximal oxygen uptake. And main reason of cardiopulmonary limitation in these patients are respiratory, cardiac, and non-cardiopulmonary reasons for exercise limitation. I mean muscle weakness, hence need for rehabilitation in this group of patients. 6 months after discharge from hospital, we can observe, especially in patients who required oxygen therapy during hospitalization, diminished total lung capacity and abnormal DCO in 56% of patients. Similarly, about half of these patients had ground glass opacities, and linear lines are seen in 15% of patients. The same observations are made by Caruso and colleagues, where ground glass opacities were seen in 34 of our patients. 1 year after discharge, we can expect that 25% of participants with abnormal pulmonary diffusion are seen, especially in group of patients with fibrotic lung abnormalities, lung injury. Besides, the negative correlation was found between the score of fibrotic injury of lung and diffusion capacity. What about pulmonary fibrosis? For the first time, Paolo Spagnuolo from Italy mentioned that this pathology is possible after 3 weeks from discharge at the same zones where only small amount of ground glass opacity were seen previously. So the disease has rapidly progressed and fibrotic changes were evident after 3 weeks. Why survivors are at risk for pulmonary fibrosis? First of all, because virus activate pro-fibrotic pathways. Secondly, because virus can directly injure macrophages, type 2 alveolar epithelial cells and endothelial cells. And additionally, we can observe cytokine-induced injury, and mechanical injury and age are also additional factors causing lung fibrosis. Who is at risk? Mainly this group of patients with a high level of C-reactive protein during hospitalization, with high level of alanine, transaminase, creatinine, or interleukin-6. Also patients who required prolonged antiviral therapy and prolonged hospital stay and prolonged steroid therapy. According to Caruso, baseline lung severity score above 14 showed an optimal performance in predicting fibrosis-like changes at follow-up. Also male sex, cough, lymphocytosis and quantitative chest computed tomography well-aerated lung volume were significantly predictors of fibrotic lung changes at 6 months follow-up with an inverse correlation. So, suggested follow-up in our survivors from COVID-19 suggested by Professor Ragu from Seattle is up to 3 years. And according to Swiss recommendation, we can answer for PICO questions very simply. Should all patients hospitalized for COVID have a pulmonary follow-up? Yes. Should all COVID-19 affected patients, including those with mild diseases, have a pulmonary follow-up if symptomatic? Yes. And yes. So conclusion is that it's urgently need for carefully follow up every 3 months in this group of patients. Very important questions as follow. Should patients after COVID who present with persistent cough have empiric inhaled topic steroids? Yes. Should patients after COVID-19 who presented with interstitial abnormalities after exclusion of an active receive an empiric systemic steroid trial? Yes. And very strong recommendation with consensus, full consensus. Should patients after COVID-19 who present with persistent respiratory symptoms undergo a rehabilitation program? Yes. Patients after COVID who present with persistent respiratory symptoms are recommended to undergo a rehabilitation program. So, tiny conclusions. Someone has said time heals any wounds. I have asked, really? Is it true in all cases? So, I think that time may heal all wounds, but it doesn't erase the scars. Despite spontaneous resolution in most patients, these scars after COVID pneumonia may be diminished DCO, diminished total lung capacity, diminished cardiopulmonary exercise level, persistent dyspnea, cough, and fatigue, with coexisting CT abnormalities, I mean fibrotic-like changes, ground glass opacity, linear changes, presented even in 20% of patients several months, even 1 year after hospital discharge because of COVID pneumonia. Thank you very much. Good morning again. I'm Dariusz ZIORA. Nice to invite you to presentation of 2 clinical cases. The first, it was a 67-year-old non-smoking male with confirmed COVID pneumonia and was hospitalized for 2 weeks in the infectious disease hospital and treated with 6 milligrams dexamethasone per day. Chest X-ray, chest CT, revealed a bilateral middle and basal ground glass opacity, as you see in this figure. No steroid treatment was administered after discharge in this patient. What happened? In the following 2 weeks, the patient experienced increasing dyspnea, resulting in hospitalization in our department of lung diseases. No sputum, no fever, no chest pain, and no hemoptysis were observed. A physical examination, blood tests, and arterial blood gas test revealed a respiratory failure with a partial pressure of capillary oxygen equal to 53 torrs, without carbon dioxide retention. and also discrete crackles over the lung fields were heard. The patient was unable to perform spirometry because of fatigue and dyspnea. CT, high resolution CT, revealed deterioration of ground glass when compared to the previous chest X-ray, chest CT examination. Considering the clinical picture of the test result, the patient was treated with the supplementary oxygen therapy, beginning with high flow and subsequently passive oxygen therapy, and a steroid therapy including methylprednisolone at the high dose of 1000 milligram per day for 4 days and half 1000 milligram per day for 3 days, followed by prednisone at the dose of 20 milligrams per day. And of course, patient was rehabilitated during hospital stay. After discharge, the patient continued the steroid therapy with prednisone, initially 10 milligram, gradually reduced to 5 milligram for 2 months, and high-resolution CT performed 2 months after the steroid treatment revealed at almost complete GGO absorption, as you see in figure 1C. Spirometry and the arterial blast gases test were within the normal range. Forced vital capacity was 94% of predicted, and FEV1 98% of predicted. PO2 equal 72 torrs. And the second case, it was 45-year-old male with a history of hypertension, hospitalized in the infectious disease hospital due to COVID pneumonia for 3 weeks. Chest CT revealed a widespread bilateral ground gas opacity with the consolidations. During hospitalization, the patient was treated with steroids, dexamethasone at a dose of 6 milligram per day. Neither lung function test nor follow-up chest X-ray were performed. After discharge, the patient received no recommendation to prolong the steroid therapy. On the 7th day of staying at home, he was admitted again to hospital because of severe dyspnea and exercise intolerance. Thereafter, the patient was again treated with steroids, receiving dexamethasone at dose 6 milligram per day, which was prolonged after discharge, prednisone 30 milligram per day. Successively, the steroid treatment and home rehabilitation, Nordic walking, were continued for 2 months in the lung disease outpatients clinic. Patients received methylprednisolone at the dose gradually reduced, beginning with 24 milligram. The chest X-ray performed and admission to the clinic revealed ground glass opacity in both mild and lower zones of the lungs, predominantly peripherally localized, with some linear opacities and consolidations. In spirometry, no obstruction was observed. However, forced vital capacity was reduced, 76% of predicted. The arterial blood gas test turned out normal to PO2 equally 83 torrs. Physio-3B to 3D presents an improvement in the follow-up chest X-ray and spirometric measurements in the presented case, subjected to a gradually reduced steroid treatment. So, these two clinical cases are example of our suggestions that a prolonged steroid therapy may be beneficial in some patients after the COVID-19 pneumonia. So consequently, in our opinion, the steroid therapy is worth considering the SARS-CoV-2 patients, especially in patients with persisting radiological changes in dyspnea requiring the supplementary non-invasive oxygen therapy. However, randomized controlled trials are required to establish guidelines for the steroid treatment in this group of patients. Thank you very much for your attention.
Ladies and gentlemen, I would like to present a simple care management of post-COVID-19 patients with a focus on non-pharmacological treatment, including some features of oxygen therapy. My name is Łukasz MINAROWSKI. I'm a second Department of Lung Diseases and Tuberculosis Assistant Professor from Medical University of Białystok. In my presentation, I will focus first at the post-COVID syndrome as itself, then the multidisciplinary team approach, then post-COVID assessment needed for further steps, simple basics of oxygen therapy in post-COVID patients, and as well with indications for lung transplantation in post-COVID patients. So severe COVID-19 patients, the illness will be complicated, as said before, by chronic respiratory failure of different levels and different forms of multi-organ failure, resulting a prolonged stay in the intensive care unit. The patients will also require some form of support with oxygen. Rehabilitation is necessary to provide a full range of proper treatment in those patients, as well as pharmacological treatment. Rehabilitation, along with non-pharmacological treatment, should be divided into different steps depending on the phase of the patient. In acute phase, the objectives will mostly focus on the optimization of oxygenation in a patient and prevention of complications. In post-acute phase, just after the patient has recovered from intensive care, the target should be the identification of management of impairments and facilitation of discharge from hospital. But the real demand and the real problems start when the patients are experiencing long COVID complications, which require optimization of functioning in daily activities, and of course production of independent patient, and in the best idea to reinstate the patient for an everyday survival. A multidisciplinary team approach is necessary to provide the patients with a full range of proper specialist care, including pulmonological specialist, rehabilitation specialist, along with cardiology consultant. If needed, a psychologist should also be a part of multidisciplinary team. Complex cases should be discussed on routine weekly matter, if needed with virtual presence of members of the multidisciplinary team. Then the proper decision making should be reinstated in a patient, and of course some kind of summarization should be also available for the members of the multidisciplinary team. Symptoms which the patients experience during the long COVID-19 are mostly the fatigue, the breathlessness, and the chest pains. Some features can also include neurological and psychological disorders like post-traumatic stress disorder, which also require a proper treatment. When the patient is burdened with a lot of symptoms. The biggest problem in our patients after COVID-19 is oxygen desaturation on the exertion and the burst of tachycardia happening also during exertion but also spontaneously during the resting time. COVID-19 survivors can also be affected with diminished innate immunity, which also be complicating our treatment plans and require prolonged antibiotic therapy and hospitalization. That is why it's necessary to provide a full and proper assessment of the patient, and according to the NICE guidelines from United Kingdom, a post-COVID functional scale is proposed as one of the steps to qualify the patients for a proper therapy. If the patient have no limitations in everyday life, the patient will regain 0 points in the scale. If the patient has negligible limitations, which do not require a constant care from the physician or from the supporting physiotherapists, the patient will receive 1 or 2 points in the scale. If the patient is bedridden or requires prolonged therapy, the patient can receive 3 or 4 points. Based on this scale, we can divide the patients into 3 large groups with a proper menu of choice for management of the patients. If the patient is without any functional impact, the proposed management will be self-management and appropriate referral to the rehabilitation programs with support of psychologist. If the patient has a slight impairment, along with self-rehabilitation programs, the patient should be also prescribed social support along with physical activity on referral under the guidance of the physiotherapist, along with psychological assessment. If the patient is moderate to severe disabled patient, the patients will require referral probably to the hospitals specializing with post-COVID-19 rehabilitation, and there should those kind of patients should be always a matter of discussion under the multidisciplinary team. When we choose a type of oxygen support to our patient after COVID-19, we also have to take into consideration the PaO2 to FeO2 ratio. This ratio is amount of oxygen which we can assess during the arterial blood gas analysis, along with the fraction of inhaled oxygen in the breathing mixture. Normally it should be around 40 to 500 millimeters of mercury, but depending on the type of disability, it can fall. Therefore, we have to choose a proper device to support our patient with the oxygen. Nasal cannula is the simplest one, along with simple mask and Venturi mask. Depending on the flow of the oxygen, we can probably choose a proper FeO2 in our patients, and therefore we can acquire a proper level of PaO2 in the bloodstream of the patient. If the patient is needing higher volumes, we can choose the partial rebreather mask or non-rebreather masks, but then we have to provide the patient with a constant care from nurses, from physiotherapists, to provide a proper placement of these devices on the face of the patient. If the patient is still not acquiring a proper oxygenation in the PaO2 to FeO2 index, we can support the patient with high-flow nasal oxygenation therapy, which is widely used in COVID-19 patients, not only in the acute phase, but also in the long-term treatment. It is possible to use this kind of devices at home setting, but it have to be used under the careful guidance of the physician, nurse and physiotherapist. Then we can achieve much higher levels of oxygen provided, along with additional post-expiratory and pressure, which can increase depending on the flow of the oxygen. Non-invasive home ventilation is a type of a treatment, especially in patients who will develop a hypercapnia, either due to pre-existing conditions like COPD, or after the hypoventilation syndrome due to the lack of muscle strength developed during the COVID-19 infection. One should monitor vital tidal volume along with the patient's well-being. The patient should be also educated well how to use this kind of devices, along with physiotherapy, which is necessary in our patient. Those of the patients who will still not be successful in acquiring a proper ventilation and the proper oxygenation in the course of long COVID treatment will require a referral to the lung transplant center and probably the lung transplantation qualification, which was in detail described by the study provided in this slide. So early outcomes of the lung transplantations should be carefully assessed. General criteria will consist of the patients younger than 70 years old with no malignancies, a proper body mass index, which also require a constant help from the care providers, and they are not able to rely on themselves in daily activities. Neurocognitive status in a patient should be also at the proper level. Those patients should be awake and cooperating with physiotherapy team. The patients with brain injury will be disqualified from the lung transplant. General condition, especially in focusing on physical therapy, should be active in all of the patients with post-COVID-19 syndrome. It means that the patient should be actively participating in the physical therapy, and the patient should be also willing to do exerted exercises under the guidance of physiotherapist. Considering the pulmonary indications for lung transplant, the patient should have 2 negative PCR results from bronchoalveolar lavage fluid obtained 24 hours apart. When this is negative, the patient can be qualified for the lung transplant. If the patient is under the tracheostomy, it should be smears from the tracheostomy. When it's available, viral cultures should be also negative, along with the bacterial cultures. For the lung transplantation indications, the evidence of irreversible lung damage should be also noted. It means that for at least 4 weeks, the patient should have respiratory distress syndrome, requiring either ECMO therapy, or the lung recovery seems to be unlikely under the proper pharmacological and non-pharmacological treatment. Therefore, our patients will require different types of approach depending on the level of impairment in all of the cases. It's not the matter of when to choose physiotherapy, but how and with which additional supplementation we will choose for our patient for a proper treatment. Thank you very much.
I would like to introduce a role on the indication of pulmonary rehabilitation in management of post-COVID-19 patient. This presentation is an attempt to show necessity of physical rehabilitation for individuals after COVID-19 disease and underline a purpose of complex therapeutic program. This program has been implemented in Poland to be one of first such program for those suffering after COVID-19 in the entire world. RS and ATS recommendations clearly indicate the necessity of rehabilitation for everyone hospitalized due to COVID-19 and possibility to participate in complex, taught individualized physical rehabilitation program when hospitalization reaches its purpose. These recommendations include necessity to conduct respiratory function test, exercise tolerance test, and psychological evaluation. Physiotherapy programs based on this recommendation are used to a different extent in Polish hospitals world and their intensive care units. Recommendation for necessity of rehabilitation based on physiotherapy methods have been also expressed in Polish. prolonged presence of after effect extend time to get back to normal life for COVID-19 victims. Rehabilitation program's goal is to remove or reduce to maximum the effects of the disease and help to regain full physical and mental fitness. The necessity of dedicated rehabilitation programs was ignited by still growing number of victims with prolonged presence of persistent symptoms. Generally, it is assumed that the symptoms may persist for more than 12 weeks, but in some cases even 6 months and longer. Research shows that long COVID symptoms are present with 10–20% patients who suffer infection. Other research show that over 35% of patients will suffer at last of long COVID-19 symptoms, even 6 months and longer from original infection. So, simply talking, overall huge number of different symptoms requires application of multidisciplinary rehabilitation. Some of post-COVID-19 symptoms require additional diagnosis and treatment, including rehabilitation. Wide range of the problem requires different ways of used therapies, their forms and methods. Outpatient rehabilitation, hospital rehabilitation for young adults and elderly. It seems to be more proper that hospital ward rehabilitation program should cover patients with multiple symptoms of highest intensity. Based on pulmonary rehabilitation program for COPD patient and scientific research, the project of complex rehabilitation program for patients suffering post-COVID-19 complication was created in Ministry of International Affairs Specialized Hospital in Głuchołazy, Poland. The program came into force on the basis of the regulation of the Ministry of Health as a pilot program in physical therapy and therapeutic rehabilitation field for those who suffer complication after COVID-19 disease. First patient started treatment in this program on September 1st, 2020. Program objectives include evaluation of the effect of the applied rehabilitation model, identification of additional symptoms and rehabilitation needs. The program suits individual needs and capabilities of the patient, including accompanying symptoms occurrence and intensification. The program is based on strict qualification to proper model of the program, complexity of the physical therapy program depending on all diagnosed symptoms, evaluation of the results on the end of rehabilitation. The program serves for over 100 patients daily. Each patient is taken care of during 3 weeks of daily treatments. On the end of rehabilitation cycle, everyone is evaluated in the same range of tests like on qualification day on the beginning. The clinical observation up to date indicate that implemented physical rehabilitation program based on target evaluation and model qualification of patient beings expected result. Recommendation for physical rehabilitation should consider individual indication, contraindication and overall condition of the patient based on medical evaluation, test performed by physiotherapist, psychological examination. Complex hospital ward rehabilitation program should include all post-COVID-19 victims with multiple and intensive symptoms. Currently, there is a need for outpatient neurological, psychiatric and pediatric physiotherapy as well as home physiotherapy. Thank you for your attention.
Katarzyna BOGACZ. I would like to tell you about post-COVID-19 physiotherapy models by Jan Szczegielniak. In his model, Professor Szczegielniak proposes few stages of rehabilitation process, begin from qualification, then therapeutic program, and finally, verification of health improvement on the end of therapy program. Qualification for physiotherapy includes evaluation of exercise tolerance based on results of 6-minute walk test, evaluation of related to 6-minute walk test dyspnea and tiredness, evaluation of oxygen blood saturation, physical fitness, ratio TLC in body plethysmography, and evaluation of patient's mental condition. 6-minute walk test is inexpensive and easy to perform method to evaluate physical exercise tolerance of patient. Evaluates of respiratory system functionality with cardiovascular and neuromuscular system as well. It is quite popular tool used in physical condition evaluation. This is test protocol example. We have to note especially distance length, walking speed, energy expenditure in MET. The walking speed is calculated from this formula. So if we have 500 meters, it will be 5 kilometers per hour. MET is calculated from this chart. On the horizontal axis in the walking speed, on the vertical axis we read MET. Chart can be found at this link. It's publication in the journal +1 by Jan Szczegielniak and co-authors. The qualification should also consider the modified Borg dyspnea scale to rate the difficulty of breathing. We can use also modified Medical Research Council dyspnea scale. When qualifying for rehabilitation, we also use the simple and safe Fullerton test to assess physical fitness. Fullerton test has 6 parts in it. We use the chair stand test, second part of Fullerton, that assesses the muscular endurance needed for getting up, walking and climbing stairs, as well as keeping balance. Saturation is another parameter that is assessed during the effort and qualification of the patient for rehabilitation. And the last important parameter is qualifying for rehabilitation. It's total lung capacity in body plethysmography. Based on the results obtained during the testing, patient is qualified for one of the physiotherapy models, A, B, C, D, or E. So this is qualification for physiotherapy models. It's based on energy expenditure, dyspnea, physical fitness, saturation, and TLC. And physiotherapy models include physical efficiency training on cycle ergometer or treadmill, and breathing exercises, general fitness exercises, walking training, resistance training and circuit training, techniques for removing secretion from the bronchial tree, and inhalation and relaxation. The models differ in intensity of basic program, but in case of additional treatments, they are prescribed individually, depending on the condition and particular needs of the patient's health. Physical efficiency training and breathing exercises are integral part of physiotherapy for post-COVID-19 patients. The key aspect of physical efficiency training is extended on time dynamic physical effort with determined intensity. Physical efficiency training can be conducted on a cycle ergometer or treadmill. Training can be conducted as an interval or a continuous mode. Every patient is monitored by heart rate. This ensures a safe and effective training program. Breathing exercises are a very important part of rehabilitation. They include relaxation exercises, extended exhaust exercises, and diaphragm exercises. Important element of rehabilitation and general fitness exercises that increase muscle strength, balance, and coordination. Program rehabilitation recommends also circuit training and elements of resistance exercises which help improve muscle strength. The method also includes techniques for removing secretion from the bronchial tree. They are drainage position, effective cough, active bronchial vibration, and chest percussion. We can use also equipment that supports effective and comfortable evacuation of mucus from the bronchial tree. It helps post-COVID-19 patients suffering from sticky mucus deposits and help to mobilize and drain them out of bronchial tree. Among the additional treatments which are prescribed individually depending on the condition and particular needs of the patient's health are respiratory biofeedback, relaxation in virtual reality condition, interactive exercises, cognitive function therapy supporting the process of short and long time memory, logical thinking, understanding, and improving communication skills. Individual treatments also include high-intensity electromagnetic field, stimulates the diaphragm, intercostal nerves, and respiratory muscles, bioelectromagnetic energy, regulation for microcirculation improvement, and vibrotherapy, which normalize muscle tension, improves static and dynamic balance, improves motor coordination, and stimulation proprioception. So this is diagram of the rehabilitation program that includes medical examination, exercise test, dyspnea assessment, spirometry, psychological examination. The next is qualification for models A, B, C, D, or E, rehabilitation for a minimum of 21 days, and at the end, final evaluation of the rehabilitation effort. Thank you for your attention.
I'm Dr. Jacek Łuniewski and I work in a research team under the supervision of Professor Jan Szczegielniak. Before I present the results of research on the effectiveness of Simeox therapy, let me tell you a few words of introduction. The first hospital in Poland where the pilot program of rehabilitation of post-COVID patients was started was the hospital in Głuchołazy. The program is described in details in Medycyna Pracy journal and it's available in open access format. The first patient was admitted to a hospital on September 1st, 2020, and up to date over 2,000 patients undergone post-COVID rehabilitation. Initial assessments of the actions taken are very promising. In people who underwent the program, we observe an improvement in all examined aspects, an increase in exercise tolerance, reduction in musculoskeletal alignments, improvement in lung ventilation, reduction in dyspnea, improvement of the mental health, which improves the quality of life. Obviously, providing objective conclusions based on scientific evidence requires time and completion of data and statistical analysis. We also note symptoms that occur in patients such as loss of taste and smell, headache, insomnia, memory problems, and many others, including cough. in 28% of patients admitted to post-COVID rehabilitation, we found a cough with expectoration of secretions, although in the majority of patients had a dry cough. 0 on that diagram means no problem at all, and 4 means the most severe problem. So you can see that the patients indicated the severity of problem from 1 to 4. That's all by the way of introduction, because today I would like to present preliminary report on the effectiveness of Simeox therapy in patients with a history of SARS-CoV-2 infection. The objective of this preliminary evaluation was to assess the effects of Simeox therapy in addition to standard care in post-COVID patients referred to a pulmonary rehabilitation and requiring chest physiotherapy due to bronchial congestion. Post-COVID patients were qualified to enter through specific 21 days rehabilitation program according to the individual physical tolerance and symptoms evaluated before start of the rehabilitation. A total of 16 patients consisted to participate in the study were equally divided into the study group treating during rehabilitation program with standard care and Simeox, and control group treated with standard care alone. The distribution of rehabilitation model was comparable between the two groups: 2 patients in model B and 4 in model C in Simeox group, and 5 patients in model B and 3 in model C in control group. In Simeox group, the device was used 6 days per week. Change in lung function, dyspnea and fatigue, oxygen saturation, exercise capability and intensity were evaluated at the end of the rehabilitation program in both groups from baseline. Descriptive analyses were used to report baseline subject characteristics. Quantitative data were compared in each group between baseline and the end of the rehabilitation using paired non-parametric Wilcoxon signed rank test, and within groups at 21 days using non-parametric Mann-Whitney U test. All analyses were performed using XL-STAT software for Mac. A P value less than 0.05 was considered statistically significant. At baseline, age, gender, BMI, lung function parameters, symptoms, and exercise tolerance were similar in both groups. About half of the patients had chronic bronchitis comorbidity in each group. The other half have no respiratory comorbidity. All patients had difficulty breathing and cough with discharge of mucus. 31% had fatigue and weakness. 31% had cognitive problems and 25% had headache. As expected, lung function was reduced in patients with chronic bronchitis compared to patients without. However, which should be emphasized, symptoms and exercise tolerance were similar at baseline. The analysis of the collected data showed that lung function improved in both groups after 3 weeks to similar extent. There were no significant difference between groups in the magnitude of improvement in any parameter or lung ventilation. Fatigue decreased in both groups, but the improvement is statistically more significant in Simeox group. Dyspnea decreased in both groups, but again, the improvement is statistically more significant in Simeox group. Improvement of oxygen saturation is greater in Simeox group than in control group. Pulmonary rehabilitation with Simeox results in a significant prolongation by almost 150 meters of distance covered in 6-minute walk test from baseline. But it's greater than in control group, where distance covered in the test improved of 45 meters. Exercise intensity rated with metabolic equivalent of task was significantly higher in Simeox group than in control group. Health status evaluated with SF-36 questionnaire improved significantly in both groups, but the difference between groups was not significant. Results seemed to be similar in the presence or absence of chronic bronchitis. Tolerance of Simeox therapy was good in all patients. These data suggest that regular use of Simeox during pulmonary rehabilitation may provide additional benefits in post-COVID patients requiring bronchial drainage. In terms of improvement of dyspnea and exercise tolerance, even in patients without respiratory comorbidity. These benefits may allow patients to recover more quickly during their pulmonary rehabilitation, but obviously larger studies are required to confirm this data. Thank you very much.
Simeox, on the one side, it is user-friendly. On the other side, it is a very efficient device, and that we use common on the patient with variety pulmonary diseases, and now especially on the patient with coronavirus infections. What is important, we have to instruct our patients on the first session what we have to do and what correct to do, and that's why we'll have on the future, on the another sessions, very good effects. The device helps to drain and make it easier to arise the mucus that is abundant in the patient's lungs. With help with Simeox, with a special drainage impulse that rise to the lungs help to rid off of this mucus.
Each patient has a 8-session program. The program shows the rebirth of the garden. That's a metaphor of the health status of the patient, and step by step, garden is getting greener, healthier. In addition to the basic therapy modules, in some cases we implement extra treatments to help with other problems, sometimes but not always related to the COVID-19 disease. Patients referred for the post-COVID-19 rehabilitation could have had other diseases or disabilities before the pandemic occurred. In other cases, unknown before health problems could have shown up because of the COVID-19 sickness. For qualified patients, we bring an option to help in such conditions with use of the equipment that we possess. Today we're trying to repeat the same results or even get better results than yesterday. During the first part of training, patient is following the rhythm and pace of this little dot on the line. When the line goes up, that's the time for inhale. When it goes down, that's the time for exhalation, which is usually 2 or 3 times longer than inhalation. 2 sensors mounted to the patient's body show the rhythm of diaphragmal and thoracic breathing rhythm. Okay. Usually it takes about 5 sessions to teach each patient to breathe in the proper way. I would say it's about 19% of patients that are able to learn and memorize the right rhythm of the breathing, and we are concentrated on the diaphragmal way of the breath, which is more effective. At the Hassan Drahakam device, we have a patient that is in training of memory capabilities that was a little bit disrupted by the COVID-19, and she complained about the more short memory problems. That's why she's undergoing the training, and right now that's her sixth stage of the training. The patient has to memorize cards which are shown through the couple seconds, and then pull same cards from the bottom on the table. That proves she memorizes the exercise. It usually takes about 20-24 sessions. In our case, we can serve the patient with the 10 sessions, but even though if it's shorter than usual, the patients declare that after the therapy, overall feeling very much improves. So we have a proof that this type of therapy works for patients with the circular problems. The therapy is based on the principle of pulse magnetic field stimulates the muscles and other tissues to work and to increase the blood flow through them.